Hello, welcome to Philosophy Roulette number 174, where we read and review philosophy papers live and figure out what is going on in philosophy, and sometimes even the world. Because America and Black Lives Matter, we're doing philosophy of race this last week or two. Let's see what we got here. Might also do, because it's Pride Month, I was thinking maybe do some philosophy of gender, because I keep going right by it. I was like, might as well do some of that too. Also, because I'm getting like to the 4th or 5th, 6th, 7th, 8th page of the what I have access to. It'd be different if I was like had institutional access, but I don't, and so it cuts down on what I can read. Although I will say I get a little bit of glee out of just showing how hard it is to read some philosophy at the moment. Of course, there are other ways around getting philosophy papers. If you do not know, you can send me a message. I will not broadcast them because I'm already reading papers without permission, but or I'm broadcasting papers without redistributing papers without permission. But there's ways around this nowadays. So thank you, Elbakian, I'll say. Yeah, the success of that website and the associated ones is just astounding in some sense. If you know the state of academic publishing, it's not astounding, but it is just astounding. It's one of the most popular websites on the internet, really, especially within academia, and not even just from places that can't afford the subscriptions to regular philosophy the journals, but the publishers, but basically everywhere. It's just easier, and this is one of the things about piracy on the internet, is that it's much easier to access content that's pirated than through the systems that are set up by the publishers. And it's one of the things about Netflix. It made it a lot. People are happy to pay a nominal fee for the convenience. The problem is if it stops being convenient, you've got 4 million subscription services. It stops being convenient anymore, which is one reason why Phil Papers is great, because it does put everything in one place. Well, let's see. Selling literature. Did I? Oh yeah, this is the Journal of Aesthetics and Art Criticism. I could just go and look at this. I could do the whole article. But speaking of selling literature, this is what we are doing here. We are looking for free papers available to read online. I read a few papers from this special edition on race, aesthetics of objects as ways of combating race-based injustice. So this one is unavailable to me. Racism is self-love. That is a weird, impressive title. Yeah, this is a review. I tend to avoid reviews and response papers, because although I've had some very good response papers, sometimes they don't sort of stand on their own, and it's very hard to I've been on all these pages already. You have to get back to 2018 now. Alright. Sometimes they don't. I read this one yesterday. That was the last one I read. That was a fun paper. Placebo effect. Oh, actually, I have this one. I saved it. Maybe I'll do that one if I can't find anything else in the next minute or two. Let's see. Yeah, it's right up here. Radical philosophy review. Agonist of race. Oh yeah, I think I looked at some of these. They were not available. Let's try. Nope. No access. I'll give it a sec to load. Maybe it'll show up. Epistemic injustice. Oh, this is available. I read actually, I think, 2 papers from this APA newsletter on Native American and Indigenous philosophy too. They were good papers. But again, same was the special issue on aesthetics. They were also good papers. Review. Social welfare, consideration India. Did I read this? I think I read this one too. Don't be ignorant was not available. I would have liked to read a paper on how not to be ignorant. Defense of Asian romantic preference. I read papers in this International Journal. No, have I done International Journal of Applied Philosophy? Maybe one. It was interesting. Critical Philosophy of Race. I don't know if I've read anything from them. Should probably just check out that journal at the moment. Book review. Racial imperialism, food traditions. That would be kind of a fun read. Food ethics. Things to know. Okay, but not. Have to go get the whole book then. Which, like I was mentioning before, is often very doable. War on cops. How the new attack on law and order makes everyone less safe. Heather McDonald. Yeah. I mean, I don't know. Cops can be very helpful, but also it's very dangerous at the moment, depending on who you are. Okay, so this is the, I'll save this one for later, because I'll go to this one here first. This is the placebo effect, the biomedical ethics. There's always a lot of biomedical ethics being published. Not available. Alright, let's give it one more click. Ooh, 520 forward. And then this is the one from this journal. Seems like the journal I should be reading right now if I'm going to be doing interesting. We've got a social constitution of the body. Thesis. Oh, this might be a thesis. A body alienation. Okay. But is that this one? Let's click on the journal and see what they have. PCDNet failed me. No page numbers. I keep forgetting to fix that. The error sound is a dog bark of some sort and a bump sound. It's weird. Okay, so let's see. I've read 2 papers from this newsletter. They were both very good, but haven't read. Let's do a biomedical ethics on ethnic health disparities, because why not? So I remember this was here, so I've downloaded it already. Oh, I've peeked at it already. It'll be a bit more sciencey, but that's okay. I glanced at it yesterday when I saved it or whatever, so I made sure it wasn't like me just reading out charts and graphs. If you are in the chat, you can grab the link to this paper here, and you can just grab it the same way I did. You click on Find on Scholar, and then it'll be there. Also, it'll be in the show notes. The link will be, if you were watching on the YouTubes or whatever, and after the fact. Okay, so here we go. Placebo effects and racial and health disparities, an unjust and underexplored connection. Okay, so introduction. To date, bioethical scholarship concerning the placebo effect in clinical settings has overwhelmingly focused on the conflict that arises between patient autonomy and clinical beneficence when placebo treatments are deceptively prescribed to patients. Well, isn't that the whole point of the placebo? That they don't know? I mean, it is a little bit, you have to lie to the people. Well, you're not, well, I don't know. This is not my area. Don't know most of it. For decades, a wealth of bioethics literature have pivoted on the question of whether it is ethical to deceive patients for the sake of their well-being, whether placebos undermine the patient autonomy, and whether deception is morally justified on the grounds that placebo effects are therapeutically significant. This paper draws attention to another key principle of biomedical ethics that we believe has been eclipsed within the placebo discourse, the principle of justice. In order to illuminate the connection between placebo effects and justice, we provide data from two subfields of research. One, findings related to several key factors thought to mediate placebo effects within the clinical encounter, and two, healthcare inequalities related to the quality of patient-physician interactions across lines of race and ethnicity. In light of this evidence, we argue that placebo effects that are mediated by aspects of the clinical encounter are likely to be unevenly distributed across different populations, and furthermore, that this uneven distribution is likely to be exacerbating health disparities along racial and ethnic lines. While the evidence we present focuses on how membership of certain racial or ethnic groups may diminish the prospects of patients experiencing placebo effects in clinical interactions, as will be discussed further below, it is quite possible that these concerns also apply to other groups who experience differential treatment within healthcare, for example, along lines of gender identity, socioeconomic status, sexuality, weight, and so on. In what follows, we offer a brief introduction to the value of patient-physician interactions, followed by an overview of the placebo effect. We describe the mechanisms by which placebo effects are produced and offer evidence that depicts their role in the clinical encounter. After a brief discussion of health disparities, we connect this evidence to research investigating the presence of inequalities in healthcare, drawing on a wealth of research that demonstrates how race and ethnicity can influence the quality of patient-physician interactions. Linking these two bodies of literature leads us to the conclusion that when it comes to the distribution of placebo effects, some individuals may be unwittingly disadvantaged in terms of experiencing their benefits. We argue that this constitutes a hitherto unacknowledged source of inequality within healthcare encounters, and that it is likely to be contributing to the significant health disparities that exist. We conclude with a discussion of the ethical implications of this connection. The value of patient-physician interactions. In 1993, the WHO extolled effective patient-doctor interactions and communication as central to doctor and patient satisfaction, to the clinical competence of doctors, and to the health outcomes of their patients. Since the publication of this WHO report, that'd be the World Health Organization, empirical research on the value of patient-physician interactions has burgeoned. The conclusion of this research has further corroborated the WHO finding that the quality of patient-physician interactions is at heart of healthcare. Mounting evidence shows that physicians have a fundamental role to play in steering the quality of the consultation by engaging in clear, understandable dialogue and providing empathetic care. Physicians' verbal skills, the content of conversation, their effective tone, the number of interruptions, as well as nonverbal cues, maintaining eye contact, warm facial expressions, upright posture, attentive listening, are cited as key components of effective empathetic communication with patients. The effects of such communication include improvement in patient adherence to medication, treatment recommendations, increasing in patient satisfaction, and benefits to patient well-being and health outcomes. In this paper, we focus on the last of these considerations, the direct benefit of patient-physician interactions on health outcomes. This link has been well documented. A systematic review of experiments investigating the role of communication on clinical outcomes found that higher quality communication appeared to impact emotional health, symptom reduction, function, physiological measures, that is blood pressure and blood sugar level, and pain control. Showing emotional support and empowering patients have also been shown to lead to a significant reduction in time spent in the hospital. While a variety of pathways are likely to be involved in this link between the patient-physician relationship and improved clinical outcomes, we are specifically interested in how placebo effects produced within the clinical encounter may improve patient outcomes. The placebo effect. Rather than consider placebos as treatments in a clinical setting or as controls in a research setting, we are interested in placebo effects, which occur in both clinical and research settings. Placebos as treatments in clinical context refers to pills or medications that are prescribed to patients, rightly or wrongly, with the intention of ameliorating patients' symptoms and or placating patients' health concerns. Although the distinction has been criticized, the so-called pure placebos, that is, sugar pills, or impure placebos, for example, antibiotics prescribed for viral infections. Coronavirus people there was a very big spike in they were reporting an antibiotic prescriptions in the last few months for the coronavirus, which of course is terrible. It screws up everything. Impure may be prescribed to patients even though there is no active pharmacological ingredient in the medication that is effective for their condition or symptoms. Such prescriptions are quite common. In the UK, 77% of primary care doctors report that they use placebos at least once per week, while in the USA, 55% of internists and rheumatologists report using placebos at least once during the previous year. Placebos in research contexts I bet this is a lie. I bet this number is higher in the US. Placebos in research contexts, on the other hand, are used as controls rather than treatments. I mean, just because I say that not flippantly. It's just we have a terrible opioid epidemic here, and there's been just like massive overprescription of opioids for basically just to make somebody a lot of money, I guess it would be, and to resell it and whatever. And so it's like they were lying about just like prescribing highly addictive drugs, and so I just don't believe that they would lie about something even less damaging to their reputation at this point. But I'm sure the researchers did a good job in trying to figure everything out. All right. Continuing. Placebos in research contests, on the other hand, are used as controls rather than treatments. In a typical randomized placebo-controlled trial, a third are allocated no treatment waiting list, a third of the participants are randomized to receive placebos, while the remaining third receive the active treatment. In this way, the two treatment groups are subject to all factors within the trial. For example, the natural progression of disease, regression to the mean, placebo effects. Apart from the active treatment, and the difference in outcomes between the two groups can be used to determine the efficacy of active treatment. So what are placebo effects? While there is no consensus among placebo researchers regarding how the term placebo effect is best defined, there is stable agreement among researchers that placebo effects are positive health changes that occur as a result of distinctive psychobiological mechanisms. While placebo effects are the beneficial effects of these mechanisms, the negative effects elicited through these mechanisms are known as nocebo effects. While many mechanisms have been cited as underpinning placebo effects, two chief mechanisms that play a clear role in placebo and nocebo effects are expectation and conditioning. Placebo effects that operate through the mechanism of expectations occur when positive clinical outcomes are brought about by the experience of anticipating them. The role of expectancy in inducing placebo effects can be seen most clearly in experiments that demonstrate the significant difference in pain relief when patients are aware that a painkiller is being administered compared with when it is administered covertly from another room. In one experiment, patients in the covert condition required a dose of 50% more painkillers in order to reduce pain to the same degree as those in the overt condition. Okay, so like if you don't see when they're doing it, then you need half as much more to get the same pain reduction. Conditioning, on the other hand, refers to repeated associations between a neutral stimulus and an active medication or unconditioned stimulus, which lead to the neutral stimulus eliciting the affected unconditioned stimulus on its own. In medical context, conditioning can result in objectively measurable placebo effects, such as when anise-flavored syrup is combined with infusions of cyclophosphamide, which reduce the white blood cells, and after several pairings, exposure to just anise-flavored syrup leads to a reduction in white blood cells. The relationship between expectations and conditioning is not entirely clear. Each mechanism may contribute to placebo and nocebo effects individually, additively, or through an interactive effect. Yeah, I mean, I do some Tai Chi. My Tai Chi teacher, he's a real traditional Chinese medicine sort of guy. He says, look, humans have been around forever. We've got tens of millions of different chemicals in our body. We have no idea what most of them are doing. Says this is why you practice Tai Chi, to boost your body. And so we have, I don't know much about traditional Chinese medicine, but he is right that there's so much we don't know about. And so how any of this stuff works is still way beyond most of us. And God forbid we ever try to actually figure out how to get traditional Chinese medicine and Western medicine to match up somehow. It does happen sometimes, but it's hard. Continuing, some symptoms and conditions appear to be very responsive to placebo and nocebo effects. For example, pain, motor impairments with patients with Parkinson's, depression, irritable bowel syndrome. While there is little to no evidence of placebo effects in impacting other conditions, for example, tumors or viral infections. Yeah, the cold doesn't give a crap. Cold is honey badger. It is noteworthy that no placebo pill or treatment is required to elicit placebo effects. They can be brought about by factors such as the prior belief of patients or the language used during treatment. Experiments have demonstrated that individuals who believe that acupuncture is an effective treatment for pain and who expect to personally benefit from it tend to report more pain relief even 6 months after treatment. Additionally, words used by physicians prior to the administration of treatments have been found to significantly impact patients' experiences of pain. In one experiment, half of the participants were told before receiving an analgesic, "You're going to feel a big bee sting. This is the worst part of the procedure." While the other half were told, "We are going to give you a local anesthetic that will numb the area and you will be comfortable during the procedure." Those patients who received the first description rated the painfulness of the injection as 5 of 10 on average, while the other group reported it as 3 of 10 on average. Similarly, in a powerful demonstration of the nocebo effect in practice, half of a group of men were told that they might experience sexual side effects as a result of a medication they were being prescribed, while the other half were not told. Of those who were told about the potential side effects, 44% reported experiencing them, while only 15% of those who were not told reported any sexual side effects. Finally, it is important to underscore that placebo effects also play a role in augmenting the effectiveness of treatment as usual, including commonly used medications such as painkillers, a point that is likely to be underappreciated among physicians. Augmenting effectiveness. Okay, so basically you have to, so it's not only the medicine, but it has to be presented in the right way to get the maximum benefit. Okay, dope. Alright, so anything to say about this section? This is just sort of, this is a rundown of the placebo effect. Philosophy of medicine is a fascinating subject. It's one of those things that, if I had a chance, maybe I'll go look at it more carefully. I'm sure there's anthologies at this point and good stuff, and there's going to be a huge explosion of COVID-related research going to be coming out, I'm sure, currently and very soon. Okay, continuing. Evidence for placebo effect in the clinical encounter. Research on the relationship between patient-physician interactions and patient outcomes suggests that several distinct components of the clinical encounter may impact placebo and nocebo effects, primarily through shaping patient expectations, although conditioning and social learning are likely to play a role as well. Here we focus on evidence related to two aspects of the clinical encounter that impact health outcomes by way of the placebo effect: clinician warmth and empathy, and support and patient engagement. So here we go. We're getting some sort of interactive thing. Is it the phenomenology of patient care that affects the outcome? It's interesting. Clinician warmth and empathy. Do I get an empathy, am I a 3 and someone else is a 4? Was this an RPG of some sort? How do we measure this? Alright. Recent research suggests that placebo effects may be mediated by the perceived warmth and competence of the clinician. Howe et al. Found that after inducing an allergic reaction in participants, those who had both positive expectations of allergy relief and who interacted with a provider who demonstrated high warmth and high competence displayed the largest reduction in their allergic reaction as measured by the size of the wheal, compared with the other groups who had negative expectations and or providers with low warmth and competence. Similarly, in an experiment involving patients with a common cold, it was found that 48 hours after the clinical encounter, those who rated their clinician as high in empathy and had high measures of interleukin 8, an immune biomarker, and reported that their cold lasted on average 1 day less than those who rated their clinician as low on empathy. Finally, in an experiment in which individuals were given either real or sham physical therapy for chronic low back pain and placed in either limited or enhanced therapeutic alliance conditions, that the results demonstrated that the degree of therapeutic alliance was just as important for pain relief as whether they were receiving real or sham therapy. So basically, you have to feel good about your doctor, or otherwise you don't get better. Okay, support and patient engagement. Relatedly, the ways in which healthcare professionals support and engage with patients have been shown to contribute to placebo effects that influence clinical outcomes. A working group examining the treatment of headaches found that patients who felt that clinicians fully discussed their headache with them were 3.4 times more likely to report that their headache was resolved than patients who did not, and that this factor was the strongest predictor of resolution. Similarly, an experiment within a family practice indicated the level of agreement between a patient and physician on the nature of the symptom of the problem significantly predicted a decline in patient symptoms. Okay, so this is So this one was empathy, and I guess this one's agreeability, warmth and empathy. And this is support and engagement. How agreeable and engaged are the doctors with the patient? In a clear investigation of how placebo effects can be generated by increased support and patient engagement in the clinical encounter, Ted Kapchuk and colleagues conducted an experiment involving 262 patients with irritable bowel syndrome randomized into 3 conditions. The first group received no treatment, but participants were required to respond to a series of questionnaires at 3 points during the experiment. A second received these questionnaires as well as sham acupuncture, which was administered in a business-like interaction with the practitioner, while the third received both the questionnaire and sham acupuncture, but the latter was delivered in a highly organized ritual, which included an augmented patient-healer interaction that include taking medication and psychosocial histories and demonstrations of compassion, support, attentive listening, 20 seconds of thoughtful silence, and expressions of confidence. Outcomes found that the adequate relief was experienced by 20% of the first group, 44% of the second group, and 62% of the third group. These findings offer a powerful demonstration of how increased additions of support and engagement within the clinical encounter can lead to incremental improvements in symptom relief for patients. Okay, so the question is this placebo, or does this is assuming here, so just to get into some more philosophical questions, does place matter? This has been actually another thing in philosophy of race, like how I was reading something on like how the power of like social arguments are. This was not actually philosophy of race, but it did. So I think maybe a paper I read just before I started reading philosophy of race stuff, how the location of where important speeches are given do matter in some sense. So there's something about the philosophy of place that's going on. It was what would I call it? And the author liked the term, like a speech act theory. This was a place act theory. So in some sense, maybe it's not a placebo, but there is something in how the overall system there can be quantified. It's not a placebo effect, but place does make some sort of more significant difference. So where it's given and how it's given, the act of the prescribing in some sense is not. Maybe placebo is the wrong thing. Maybe it's a prescription act theory that we have to develop here, because I'm starting to think that, look, maybe you have to be in a right sort of the state the person is in when the prescription is administered, and maybe how, like, before and after the way things are prescribed makes a difference to the uptake of the medicine. Maybe you can't just give some pills and keep going, because like if they take it and they're like running around, maybe they need to be in a relaxed state when the medicine is given. Just like you can't have like food before doing a surgery or something because you puke all over the place, it may screw up the numbers. Maybe you need to be in a relaxed state to actually do this. I mean, how much do we know about the like lead up to procedures and when people take pills? I mean, I don't know like how often do we track what did they do for the last like 5 hours before they took the medicine. I mean, it's like take with food. That's like what it says on the prescription bottles. Is that enough? Maybe we need to do more on that. And it's not just placebo, but sort of how and when the medicine is administered. Okay, continuing. This evidence demonstrates that, for certain conditions and symptoms, placebo effects mediated by the clinical encounter play a significant role in contributing to patient outcomes. In light of this, the next section offers a brief overview of the prevalence of health disparities along racial and ethnic lines, and in the following section, we examine data related to inequalities in care that correspond to the two aspects of the clinical encounter discussed above. Yeah, so I worry that my last word right there is basically that there might be, even if it's grouped under the placebo effect, there might be more that we could actually study about, like the lead up and the conditions under which that we might not consider placebo, but like objective in some sense. Of course, like I mentioned above, if you look at other theories of health, not the Western healthcare paradigm, then of course you get much more into that sort of thing. The question is how to square that with the healthcare, Western medicine. So, yeah, like what was it, Prescription Act theory, or what did I call it? I forgot already. Yeah. All right, continuing. Health disparities. A substantial body of evidence suggests that one's race and ethnicity can significantly impact the healthcare one receives. In 2003, the Institute of Medicine, now the National Academy of Medicine, published a landmark report entitled Unequal Treatment, Confronting Racial and Ethnic Disparities in Healthcare, and concluded that evidence of racial and ethnic disparities in healthcare is, with few exceptions, remarkably consistent across a range of illnesses and healthcare services. Evidence suggests that while Asian Americans are the most likely population to die from cancer, they are the least likely to be recommended for cancer screening. Did not know that. That's terrible. In Canada, Aboriginal people are half as likely to advance from referral for transplantation to the transplant waiting list as non-Aboriginal people. Black and Hispanic patients in the United States of America are significantly more likely to undergo primary cesarean delivery than whites, 54% and 12% respectively. That is a huge number. Yeah, the mortality rate during birth in the U.S. for black people is just terrible here compared to the average or whatever for white patients. Recent findings show that disparities have not narrowed since the publication of the IOM report, although the American Medical Association recently amended its Code of Medical Ethics to include a section stipulating that both individual physicians and medical professions have an ethical obligation to increase awareness of health disparities and to put in place measures to eliminate them. Yeah, this gets in the news pretty regularly, how bad it is nowadays at least. So at least maybe awareness is up. And I mean, pretty regularly for this stuff is once in a blue moon. Many explanations have been given for disparities in health outcomes. These explanations can be roughly divided into four categories: environmental factors, factors found in healthcare systems, patient factors, and clinician factors. Environmental explanations focus on socioeconomic status, stress that results from discrimination, as well as differences in exposure to hazards or pollutants. Explanations related to healthcare systems point to the ways in which inequality grows as a result of differential access to care, patterns of referral, language barriers, bureaucratic difficulties, and the fragmentation of healthcare services. Patient factors examine differences in attitudes and behaviors related to health, adherence to treatment, potential genetic differences, and how stereotype threat might impact minority health. Finally, clinician factors involved examinations of how discrimination within patient-physician relationship, resulting from both implicit and explicit bias, might lead to differences in terms of both screening and treatment. While each of these factors contribute to the existence of health disparities, here we identify an unacknowledged avenue by which Differences in health outcomes between populations may be exacerbated by way of placebo effects mediated in the clinical encounter. Yeah, I mean, this you can just go on and on and on about, at least in the U.S., about the problems between the different races and health outcomes here. So how do we explain it? So let's look what they say. Evidence of inequality in the clinical encounter. Aspects of clinical encounter, such as physician communication and engagement and setting patient expectations, may be considered by health providers integral to the art of medicine, but dispensable when it comes to objective outcomes. As the research cited above demonstrates, this is not the case. Therefore, it is worth taking a closer look when a systematic review of patient-physician communication concludes that minority patients are less likely to engender empathic response from physicians, establish rapport with physicians, receive sufficient information, and be encouraged to participate in medical decision making. In line with this, we present data below from research related to inequalities in healthcare, mirroring the two categories discussed above: clinician warmth and empathy, and support and patient engagement. I mean, nowadays, I think what they're doing in hospitals around here is, because there's so many languages, they have basically one of those like tablets with someone who speaks the language, and they're off in like some room maybe nearby or something, or maybe in a central location. And then at least they can communicate with the people in their native tongue, and apparently that's been very helpful to get people to understand what's going on. Just having, because they can't have, there's so many people with so many languages here in New York that you're not going to have everybody everywhere. But even just having a translator on screen that can be like friendly to the people makes a big difference. So, here we go. Clinician warmth and empathy. Warmth and empathy expressed by clinicians appear to differ across populations of patients. For example, one experiment involving independent observers who watched interactions between patients and physicians through a one-way mirror found that physicians spent more time with white patients and scored higher on the dimensions of interviewing and empathy when they were meeting with white patients as compared with Latino patients. Another study found that physicians used significantly fewer positive expressions when engaging with Latino patients as compared with non-Latino patients, but that levels of empathy were similar in both groups. Further investigations into inequality in the clinical encounter show that high scores on implicit racial bias, as determined by a test derived from implicit association test, correlate with lower ratings of positive effect in patients and higher ratings of clinician-dominated dialogue during the encounter. Another analysis of patient-physician interactions by independent coders who listened to audio recordings of patient visits found that physicians were more contentious with black patients than white patients, and guessed that black patients were less satisfied with the care they received. Finally, and while not a direct measure of empathy or warmth, a study by Van Ryn and Burke found that after meeting with a number of patients and then completing short surveys about each of them, physicians were more likely to see black patients as less intelligent, more likely to engage in risky behavior, and less likely to adhere to medical advice when compared with white patients. Physicians were also less likely to agree that black patients were the kind of person they could be friends with in comparison with white patients. That doesn't sound very nice. Okay, it is just sort of results. Not too much to say there. Support and patient engagement. Differences in support and patient engagement appear to be influenced by race and ethnicity as well. In an experiment involving patients with breast cancer, it was found that physicians spent significantly less time engaging in relationship-building behaviors with black patients as compared with white patients. Independent raters of audio tapes of patient visits reported that when clinicians were interacting with black patients, they engaged in 33% less patient-centered communication than when they were speaking to white patients, showed less positive effect, and were 23% more verbally dominant. Studies have also found that when white physicians interact with black patients, they tend to engage in less shared decision-making and provide less information than when they engage with white patients. Corroborating this evidence, Cooper Patrick et al. Found in telephone survey that black patients tend to rate their medical visits as significantly less participatory than their white counterparts, while another experiment found that black patients give worse ratings for patient-centered care to clinicians with greater implicit racial biases, as measured by the IAT. Okay, evaluating the evidence. Disparities in placebo effects. So here we go. The effect presented above urges us to dig deeper into how differences in the delivery of care impact the distribution of placebo effects within the context of care. While no direct evidence speaks to how placebo effects are influenced by inequality in the clinical encounter, these two bodies of literature offer strong indirect evidence to suggest that the differences in the placebo effects are occurring along lines of race and ethnicity. While the primary mechanisms of expectations and conditioning that contribute to placebo effects are likely to be mediated by expressions of warmth and empathy by physicians, as well as degrees of support and patient engagement, it can be directly inferred from the evidence presented above that these aspects of the clinical encounter arise significantly less frequently within clinical interactions with minority patients. This suggests that individuals who are members of racial and ethnic minority groups may receive less therapeutic benefit via placebo effects and experience more harm via nocebo effects. Furthermore, this unequal distribution of placebo and nocebo effects, we argue, is likely to exacerbate existing inequalities related to health outcomes along lines of race ethnicity, constituting another route by which health disparities are exacerbated. Further direct evidence for the role of placebo effect in health disparities can be found in the high prevalence of health conditions that show robust response to placebo and nocebo effects in racial and ethnic minorities. As mentioned above, these conditions include pain, psychiatric disorders, Parkinson's disease, and several types of functional somatic syndromes such as irritable bowel syndrome. In line with this, several types of pain, for example, chronic malignant acute cancer and Parkinson's disease, have been shown to have disproportionately high prevalence in racial and ethnic minorities. Interestingly, evidence suggests that while racial and ethnic minorities do not have an increased lifetime risk of psychiatric disorders, the persistence of such disorders is more common among minorities, perhaps as a result of differences in care. Unlike these other conditions, irritable bowel syndrome appears to be more prevalent among whites than racial ethnic minorities, although this gap may be narrowing. Of course, evidence for racial and ethnic disparities in placebo response conditions does not imply either that the placebo effect caused these conditions or that there aren't other important explanations for these disparities. For example, socioeconomic status, exposure to stress. The data, however, do provide additional indirect evidence for the role of placebo and nocebo effects in contributing to racial and ethnic disparities. Okay, again, I'm just wondering about, like I said, the place of administration. Does the state of the person, like, are we getting people all wound up before they're getting their medication, and is that messing up stuff? It's not only the empathy and interactions, but how the state of the person. So, interesting. Okay, but continuing. Either way, it's going to have to be cashed out somehow. Ethical implications. So now we're getting to the ethics. Let's see, how much more of this we got? I got 2 pages. Yeah, that's about it. Okie dokie. Yeah, these double columned papers are twice as long as the other ones. A little, about 16 pages of a non-double column paper. Ethical implications. What can we take away from this? There are many directions a discussion of the ethical implications of the link between placebo effects and racial and ethnic inequalities in healthcare could be taken, but here we focus on 4 ethical questions in particular. These questions include whether or not an uneven distribution of placebo effect constitutes an injustice, how the standard of care might be expanded to harness the placebo effect and counteract these inequalities, how providers' implicit biases might be reduced, and how other lines of inequality might intersect with placebo effects and health disparities. Unequal distribution of placebos as an injustice. As we have hypothesized, health disparities along racial and ethnic lines are increasing as a result of an uneven distribution of placebo effects as mediated within the clinical encounter. This raises the question of whether such disparities constitute an injustice. It might be granted that other contributors to health disparities, such as difference in treatment or diagnosis, can be reasonably thought to as instances of injustice, but that patients who are fortunate enough to engage with a supportive and empathic physician are merely the recipients of a lucky therapeutic boost to their care. One might argue that the former scenario has serious repercussions for individual health outcomes and implicates the clinical competence of physicians and so constitutes an injustice, while the latter scenario only involves different degrees of friendliness, which cannot be significantly impact health outcomes and does not violate reasonable expectations of physician behavior, and so does not constitute an injustice. With regard to the impact of such a scenario on clinical outcomes, as outlined above, aspects of the clinical encounter that contribute to the distribution of placebo and nocebo effects can significantly influence clinical outcomes across conditions and symptoms. Research has demonstrated that saline injections delivered with positive verbal suggestions can have an equivalent impact of 6 to 8 milligrams of morphine administered surreptitiously, suggesting that placebo effects are quite powerful indeed. Taking this into account, an uneven distribution in placebo effects might appropriately be thought of as freely administered treatment for certain privileged demographic groups. The more serious objection holds that while differences in diagnosis and treatment are central to a physician's clinical role, placebogenic aspects of the clinical encounter, such as warmth and support, are above and beyond what we require from our doctors, so any failure to express these qualities cannot constitute an injustice. However, the fact that the role of these qualities in impacting health outcomes is not widely acknowledged cannot constitute a defense. Medical practice must follow the evidence. Professional medicine is concerned with the appropriate prescription and use of medication and surgical interventions. Call these the tools of medicine. However, the fact that other tools such as empathy may not be conventionally considered a part of this toolkit does not thereby constitute a justification for them not being classified as such. Rather, it merely reflects the habits and practices of orthodox medicine. Force of habit, however, is no defense against ignorance. Practices of orthodox medicine, welcome to the U.S., where everything is governed by money, and they're trying to see more and more patients in less and less time to get more and more paid. And so I don't know if this is orthodox medicine, but it's definitely the capitalist economic forces trying to get more patients in and out the door in many of these cases. And so that would definitely be cutting down on quality patient interaction time. So I don't know if the use of orthodox, I don't quite agree with the use of the word orthodox right here, but it's definitely the way things are at the moment. But there's other factors that are contributing to this. It's like the old doctor going, like the old-timey doctor going house to house along the prairie and like talking with the people and being like the family doctor. That doesn't make economic sense at the moment. And so this is I don't know what, this may just be the economic capitalistic sort of state of medicine we have in the U.S., or maybe other parts of the world, I don't know. But so that's an issue. What counts as orthodox here? All right, but either way, the point still stands. There's nothing against the author's point here. In these ways, we argue the unequal distribution of placebo effects, which we argue is likely to be contributing to systematic disparities within the delivery of patient care, constitutes an injustice. Let's see, do I have anything else to say about this? Again, this also here, all these things that they're saying, that like maybe this is just the way things are, it's the way we have been measuring outcomes. So you could call this also a problem of how you measure what counts in this. In the paradigm of Western medicine, it is the the tools of the healthcare thing. The tools have been to use like what the where was that little line where the tools of healthcare? Can I find it quick? I don't know. Tools of medicine here. Yeah, it was just right there. So this sort of thing. Professional medicine is concerned with the appropriate precision of medications and surgical intervention. Call these the tools of medicine. So these other tools. So there's a question of, just because we were measuring something according to these tools doesn't mean we can't measure other things. And then whatever counts as a tool, as they're saying here, the classification. So this is also not just the question of the capitalist version of this, but the Western medical paradigm of what counts as care is under question right here. So this is a good paragraph. Okay, expanding the standard of care. When medical students are taught that the standard of care for a particular condition, they learn about which interventions are known to produce the best results, given the population they are working with and given the other risks present. What they are not typically taught is the way in which the manner they administer an intervention can impact clinical outcomes. The evidence above raises the question of whether the standard of care ought to be expanded to include not just what treatment ought to be administered, but how treatment ought to be administered. This question brings with it a host of practical and ethical issues, including what conditions would be appropriately included in the enhanced standard of care, how to communicate with patients regarding these aspects of treatment, whether one might bill for the manner in which a treatment is delivered, and whether the placebo maximizing aspect of the clinical encounter can truly be taught. While more research is surely needed before such a shift could be implemented, it is worth briefly exploring these questions. I have something to say on this. Briefly, many years ago, I had a job in a hospital, and my boss was, she was very cool. She was probably she was the best boss I ever had. She needed some surgery, and she was dating some ungodly wealthy person at the time. I don't know if they stayed together. I left that job years ago. I haven't kept in contact, which is too bad. But they had in the hospital these high roller rooms. Basically, it was like a high-end hotel built into the hospital. Instead of just getting a normal medical room, which is fine, but they would get basically a hotel room with all the medical equipment in it. And so it's you were getting basically a spa treatment. And maybe that's how hospitals will be in the future. There'll be more these high-end spas. And because he was paying for it, and so it was just we went up there to visit her one day. It was just gorgeous. It was so nice. It's well, that's what the rich people are getting. It's okay. So yeah, and she got better. So that nice outcome. Importantly, yeah, it was it wasn't anything critical. It was just some sort of surgery that maybe it doesn't matter. Don't quite remember. Anyway. Importantly, if the standard of care was expanded to include not just what, but how medical interventions are delivered, it would first be essential to follow the evidence in terms of what kinds of expansion would be warranted. As mentioned above, research into placebo and nocebo effects show that some symptoms and conditions are likely to be impacted by the aspects of the clinical encounter discussed above, while others may be unresponsive. Experiences of pain are highly susceptible to placebo effects, and as are some psychiatric disorders, including depression and anxiety, Parkinson's disease, and several functional somatic syndromes, so these might be better candidates for expanded treatment models than others. Then again, it is likely that anyone in poor health can stand to benefit from positive direct effects of therapeutic communication. While tumor growth may be unaffected by the clinical relationship, cancer-related fatigue has been shown to be responsive to placebo treatments. Yeah, I can't see why it wouldn't. I had cancer. Yeah, you're dead tired. I'm sure it would work somewhat though, but I tried to stay awake some days. It didn't work. In addition to the standard of care was expanded to account for the powerful role placebo effects can play within the clinical encounter, this would raise difficult questions regarding how the patient should be told, given the physician cannot avoid communicating in one way or another and framing information that they provide. It has been observed that a tension arises between commitments of transparency that are commonly embraced within medical codes of ethics and the way in which placebo effects remain unacknowledged in the clinical setting. Interesting. Yeah, they don't want to say things that they don't know how it works, I'm sure. If true transparency is the goal, shouldn't patients be told that the number of minutes, smiles, and tests they receive during their visit may all impact their health? Should they be informed about possible disparities in the delivery of care? Indeed, the latter question becomes even more troubling if we try to picture what transparency might look like, since telling patients that their quality of care may be undermined due to non-clinical factors like race could lead to an increase in the likelihood of nocebo effects occurring. Yeah, so if you're told that you're going to get bad care, it's going to be very bad for you. Translating these findings into improved outcomes in practice will not be an easy task. In fee-for-service models of healthcare, I was just saying over here about this orthodox, where clinicians are reimbursed for components of treatment piece by piece, it may even be considered necessary to bill for placebo maximizing aspects of the clinical encounter in order to see them implemented in practice. This could bring about a bizarre reality in which clinicians are reimbursed $20 for shaking hands with a patient, $30 for 20 seconds of thoughtful silence, and $50 for a short conversation about the weather. These may seem laughable, but some evidence suggests that paying for such improvements within the clinical encounter may come out on top within a cost-benefit analysis. As mentioned, it has been found that better communication skills and increase in emotional support can lead to significant reductions in post-surgical days spent in the hospital. Well, yeah, I mean, if you're reimbursing them for seeing fewer patients here. You don't have to necessarily do these things, although these things are specifically helpful. But again, if you're doing pay for procedure, not pay for outcome, which they have been talking about recently, then you have to slow them down some way. And so slowing them down, if you're not doing pay per procedure, might be to reimburse them for not doing as many procedures. I mean, that's what it would be. I mean, the cost benefit. Another question arises in terms of whether the aspects of the clinical encounter that make a real difference are aspects that can be readily taught to clinicians. Oh, of course they can. You can teach people to act nice at least. You don't have to be nice, they have to think you're nice. That can be taught. While some factors such as the length of time spent with the patient may be easy to increase, others it might be argued, such as degree of empathy expressed and the participatory style of communication, are harder to teach. However, there is encouraging evidence that short training interventions can significantly improve physicians' communication skills and perceived levels of empathy among patients, of course. And basically, the training can also knock out some stupid bad habits, too. It's like, don't do that one thing. And then, of course, you're going to knock out people being doing bad things that are sabotaging it. So even it's like, don't blunder, as people online have been saying. On Twitch, people have been talking about chess. Everything's a blunder in chess when you blunder a piece. So if you can knock out the blunders, you'll just be much better. You don't have to be good. You have to not do any stupid mistakes. I mean, it's like that basically everywhere. Indeed, it was the introduction of short courses which focused on teaching surgeons to increase patient empowerment and communicate better that led to reductions in days spent at the hospital mentioned above. These findings suggest that, at least to a certain degree, placebo maximizing behaviors may both be teachable and, in the long run, increasingly feasible in clinical encounters. Perhaps more important, however, is eliminating the behaviors that lead to differential treatment of minority patients in the first place. I don't know about this. Like, more important, I don't know if we're going to counter like racism in this, but like I said, knocking out the blunders, like you can keep people from making stupid mistakes. That I think is the low-hanging fruit. Tackling racism is much bigger, but still, I mean, of course it would be a good thing, but you're not going to change all of doctors. All right, continuing. Reducing implicit bias. As noted, an abundance of research shows that patients from racial and ethnic minority groups are vulnerable to inferior care. A wealth of indirect evidence suggests that these differences in care are likely to be, at least in part, the result of implicitly held biases related to race and ethnicity. While most physicians are unlikely to explicitly report biases toward minority groups, like the rest of the population, most display substantial implicit biases grounded in racial and ethnic stereotypes, at least sometimes these biases appear to correlate with clinical decision making. Evidence also suggests that reliance on stereotypes tends to increase with cognitive load, suggesting that healthcare professionals who are typically engaged in many tasks while under time pressures are more likely than others to fall back on such stereotypes while making decisions or interacting with patients. Some have also hypothesized that the culture of medicine may exacerbate tendencies to frame one's experience through stereotypes, either through derogatory humor or through the ethical erosion that happens to medical students during their training. Unfortunately, the nature of these implicitly held biases as unconscious and automatic beliefs poses a significant challenge in terms of both identification and reduction. Yeah, it takes more effort to not to do things in a more sophisticated way. If you're gonna be dead tired and have no effort, you're gonna like revert to like the simplest sort of explanatory features, which ends up usually being, of course, more stereotypical than the actual reality. It's just you have to you don't have time to process what's going on, so you get the most simplest sort of like the least sophisticated understanding of what's going on, which is going to cause all this crap, or at least contribute to it. Fortunately, a growing literature from social psychology has been exploring techniques for reducing implicit racial biases, although methodological weaknesses and a lack of randomized control trials suggest that conclusions from this realm of research should be approached tentatively. Despite these shortcomings, a review of this literature suggests that counteracting racial bias among healthcare providers should involve strategies that illuminate what underlies biases, motivates practitioners to reduce them, emphasize partnership within the clinical context, encourage confidence related to interacting with patients from different ethnic or racial groups, and help providers to experience empathy in both its cognitive and emotional dimensions. Research has also found that requiring students to take the IAT and reflect on their own biases and incorporating curricula related to health disparities and minority health into medical school can be effective in reducing implicit biases. Techniques that have shown promise outside the clinical context include repeated exposure to counter stereotypes and increased contact with those who are the target of one's biases. Unfortunately, the long-term effects of these training interventions are not known. Another important area of related research explores the impact of racial concordance on patient experiences. Some evidence from this realm suggests that when patients and clinicians are of the same race, patient visits are longer, satisfaction is higher, more positive effect is expressed, and patient and clinician assessment of pain are more closely aligned. These outcomes align well with the aspects of clinical encounter that contribute to placebo effects discussed above, suggesting that perhaps a way to increase placebo effects in minority populations is to increase the number of racially concordant patient-physician relationships. However, the experiments measuring the impact of racial concordance mentioned above did not examine health outcomes, and a recent meta-analysis suggests that there is inconclusive evidence for the claim that racial concordance has a positive effect on clinical outcomes. It is likely that more research is needed before any efforts are made to match skin tones or ancestry within clinical settings, especially given the unintended effect of perpetual racial segregation this could lead to. I mean, I'd say basically that if you're still working in the Western medicine paradigm, you're going to have basically the same outcomes no matter what the race of your doctor is, because basically they've been trained in the same way, and so they're not really doing what they're saying about empathy and like time spent with the patient and engagement. I mean, because it's not valued in the Western medicine. So there might just be incidental cases where that happens because of a shared history. But I mean, that's like saying all white people get along. I mean, that's crazy. So it'd just be like irrational to think that like everyone of a certain culture happens to get along, and therefore the medical outcomes are going to be a better. Yeah. So I mean, it would be more people, of course, where they actually happen to get along, but that's so it might just, when you have more in common, there's more likely to get along, but again, it would be very hard to guarantee that even within race. I mean, yeah, like all white people get along, all black people get along. I mean, where have you been living? Other forms of inequality. While the discussion above has focused on inequality in relation to race and ethnicity, there are countless other individuals who face stigma, discrimination, and bias within healthcare settings. Difference in patient weight, mental health, substance use, socioeconomic status, age, gender identity, sexuality, attractiveness, criminal records, HIV status, street involvement, and marriage status, among other factors, all contribute to experience of discrimination and differences in treatment within clinical settings. This suggests that individuals from any of these groups may be less likely to experience placebo effects during healthcare interactions, further increasing inequality of health outcomes along countless other dimensions. In addition, for those patients among whom two or more of these identities intersect, negative experiences within healthcare may be even more likely. The ubiquity of discrimination within healthcare settings is alarming and raises pressing questions related to justice. In thinking through the possibility of implementing strategies to increase placebo effects within the clinical encounter, arguably the greatest priority should be given to those who are most vulnerable to stigmatization within healthcare settings. Concerns arise, however, regarding whether flagging patient risk for discrimination and intentionally treating them differently is the right solution to reduce the effect of stigma. The many forms in which bias appear within clinical settings is an important issue, however, and the way in which it may be directly contributing to an increase in health disparities by way of placebo effects has has to date been overlooked. Further investigation into the ways in which this occurs, the extent to which it occurs, and the ways in which we can ameliorate its effect, we argue, should be a research priority. Conclusion. On a slightly more positive note, it is important to refrain from giving clinicians more credit and more blame than they deserve. If we consider the mechanisms by which placebo and nocebo effects appear to operate, the expectations and conditioning, it is clear that there are many other avenues by which placebo effects are likely to be initiated. The elicitation of placebo effects through social learning has been well documented, and the role of culture and community is likely to be significant as well. This suggests that both harnessing placebo effects and counteracting nocebo effects are possible outside of the clinical encounter, and we would do well to avoid seeing the clinician as all-powerful when it comes to shaping clinical outcomes. There is hope that a better understanding of placebo effects can help us to see ways in which these effects can be employed to increase the agency of patients in their own care. Preliminary research into the efficacy of open-label placebo treatments has shown promising results. There are also hope that placebo conditioning may allow for reductions in medication dosages, which will thereby minimize harmful side effects. While bioethical discussions of the placebo effect have long focused on conflicts raised between patient autonomy and beneficence, the intersection of placebo effects and justice deserves sustained philosophical treatment as well. We've argued here that an important and unacknowledged route by which disparities in health status may arise through differences in the distribution of placebo effects. Aspects of the clinical encounter, including the tone and emotional presence of the clinician and the support and engagement involved in a consultation, have been found to directly shape clinical outcomes and yet are experienced differently by different racial and ethnic groups. This constitutes a significant injustice related to clinical care. We suggest a closer look at the relationship between inequality and placebo effects is long overdue. Okie dokie, what to say? Good article. Like I said, how do we understand the tools of medicine? As they said, what counts as the orthodox is what I was saying, the fee-for-service models. What counts as the so how do you measure things is, of course, not considered part of the toolkit. And they were saying empathy. I mean, I was just saying, look, maybe the sort of the situational understanding of like medicine has to be analyzed much, much more closely, that there is the prescription act of the act of prescribing is not what we think it is. And so maybe even still in the Western model, being able to analyze the status, the things around the prescribing act make a big difference. And so just throwing this all under placebo effect might be we're gonna have to start breaking up the placebo effect into a much more fine-grained understanding of where the placebo effects occur and how they occur. Let's see, anything else to say? So I think the author has covered a bunch of interesting bases, especially over in this area. Expanding standards of care. Yeah, how do you do this? I mean, in this last little bit, these other inequalities, we have terrible healthcare outcomes. I mean, it's just people. I mean, the current events here bring it up for the LGBTQ community. In the last few days have blown up again. Thank you, Donald Trump. And so these sorts of things really matter. And so how do we, again, with the current economic model does not usually do outcomes, and so how do you actually get doctors to spend more time, especially doing things that they probably find uncomfortable, which is this reducing bias training. But that's so hard. I mean, to change, that's a massive sociological change. As I was suggesting, I'm sure there's the trainings can sort of knock out some of the low-hanging fruit that are just the dumb mistakes that people make. So I think that would go a long way if we could start identifying just basic aspects of how to boost placebo effect by not doing some of the dumb things that we currently have been doing in Western medicine. Yeah. I don't have much else to say. Of course, if the chat has anything to ask, please do so now or hold your peace. Okie dokie. Yeah, so I guess I'll be back later today, and with more philosophy. Have a good day and stay safe out there, everyone.